Hello and welcome to this Vālenz webinar, Next Generation RBP Roundtable, Evolving Collaborative Approaches for a Balanced Reimbursement Strategy. I am Aaron, your host, and we're delighted to have you join us. Today featured as our speakers are Rob Gelb and Adam Russo. So now to introduce our speakers. Leading today's conversation is Rob Gelb. Rob is Chief Executive Officer of Vālenz, one of the nation's leading medical cost reduction and claims flow management organizations, offering expanded solutions to support the self-insured industry. Joining Rob is Adam Russo. Adam is the co-founder and chief executive officer of the Phia Group, an experienced provider of healthcare cost containment techniques offering comprehensive claims recovery, plan document, and consulting services. So Rob, that wraps it up for me. Please, over to you now. So you begin.
Absolutely, Aaron. Thank you. Adam, good to see you, brother. How you doing today?
How are you? I'm doing great, my friend.
Good to see you. And
Looking
thank you
good.
for all you are as well. It's good to see everybody out there and know that you're listening in. So as we begin, thought we'd have a couple of opening remarks that kind of give you the foundation for what we put together for you today. Number one, I don't know if you're familiar with it, but there's a book in 2007 that was published by Marshall Goldsmith called What Got You Here Won't Get You There. That's the basic tenet of what we're here to talk about today. This entire concept of if you're doing things that you were doing 2 years ago, 3 years ago, 4 years ago, and expecting to get rapid, accelerating improvement and change in your program, you're missing the mark. And that's really what we're here to talk about. So when Adam and I got together and talked about an exchange and a dialogue on the topic of RBP and reimbursement strategies, it really was with this idea of all the stakeholders and shareholders in the self-insured community to have this discussion about what we're seeing, what the changes are that are going on, what things are going to potentially affect how you look at going forward, and then how do you prepare for an evolving environment that's going to have constant change as the platform for consistency, ironically. We're not here to give you infomercials about Phia or Vālenz. That's not our plan. No, we're not here to conclude with here's the final page and a turnkey solution, just implement this and you'll be successful. Although Adam and I will both tell you we swell with pride when we think about our companies and our people, our customers and our partners. That's not the focus of today. Whether it's a stakeholder equation of payer, partner, and patient, or whether it's an economic equation that ties back to cost, quality, and utilization, that's really what we want to have a conversation about today and talk about meaningful change that kind of drives us forward. So with that, Aaron, if you wouldn't mind maybe putting that first poll up for us. Thank you so much. And Adam, as people are responding to this, I don't know if you wanted to have an opening comment on some things that's been on your mind.
Yeah, so obviously, well, first I want to say thank you for inviting me as a guest. You know, one of the things I realized, and, you know, I never read that book until you brought it up to me, Rob. I mean, you read a lot of things that I obviously don't have. I guess you just have a lot more free time than I do, but I do have 4 little kids. They take up a lot of that. I spend a lot of time reading those, you know, well, not the banned Dr. Seuss books, but the ones that are allowed to be read. I spend a lot of time reading those books with them. No, but honestly, we've seen a massive evolution when it comes to reference-based pricing, right? I mean, let's be honest. 10 years ago, any alternative to the PPO structure was things that people just reached for, right? They wanted it. Why? Because they couldn't just keep looking at premiums going up, co-pays going up, deductibles going up, as we have seen year over year. But obviously, since last March, right, we've been in this pandemic now a year, right? It's a year.
Exactly.
So we've had a lockdown. You know, it's even changed that much more. So I think this question definitely resonates to that effect.
Absolutely. Well, we're getting close to a good number here. It looks like some people are responding. And we'll probably end the poll here in about 10 seconds or so. But I think, Adam, if you look at some of these results, and we will broadcast those results when they're done for everybody, I think this is aligning with some of your thoughts on the topic.
No question about it. You know, the crazy part is, you know, COVID obviously has had such a massive effect on our families, on our behaviors, but it truly has changed the industry, the health insurance, healthscape landscape in a way that I don't know if we'll ever go back to the old ways. I think
I
we're
would
good
agree
now,
with
Matt.
you.
I think we're good now, Rob. What do you think?
Yeah, I think so too. Adam, if you want to close that out, or Aaron, if you want to close that out, let's broadcast those results. That's fantastic. Thank you. So what you'll all see there is about 85% agreed with that comment. And I think that for us, for Adam and I, as we were walking through this, this is the why for today's discussion. There's a lot of interesting information about health systems. A recently published, this was in January of this year, by Health Affairs blog. Over the course of 2020, hospitals lost an average, Adam, an average of $50 billion in procedure revenues. This is per month, brother, per month. While insurers reaped record-breaking profits over the same time period from avoided claims. And so that's, right, go ahead.
So take that, what does that mean, right? 50 billion with the B a month, okay? So you add that and add to it surprise billing legislation, right? Balance billing. I mean, if anything, if you're a CFO at a hospital, what are you supposed to do with uncollected bills? Let them go?
Correct.
You have to chase that money. But then on the opposite end, you just mentioned record-breaking years for who? Insurance companies, right?
Health insurers, absolutely, man.
Hey, can someone tell me, and again, I'm not talking about nationally, but in the state of Massachusetts, the average increase in health insurance premiums from 2020 to 2021, the same people, the same organizations that had record-breaking profits somehow had the ability to go to brokers who were on this call and say to them, yeah, we're going to still increase your rates by an average of 11%. Huh?
It doesn't make any sense. And so as you're thinking, so tying it back to the essence of this conversation, as you're thinking of reimbursement strategies, this is a key area of thought relative to what Adam points out. If you think a health system is simply going to accept you giving them a cut in payment without logic or rationale behind it, it's going to be a challenge. So we're going to need to think differently about how we move forward. Tie that in to virtual medicine, the acceptance of virtual medicine. So there's some published information. Aon did a great study. By the way, for those in the audience, all of these reference points are going to be in a bibliography that we're going to share as a reference point for you to read the articles if you're interested in them and these studies. But Aon did a study, and there's two really key points in there. One is physicians, typically 22% they had a virtual episode of care of some sort with a patient. It's up to 80% during the pandemic, four times. And we've seen an increase in virtual visits in general from 11 to 46, nearly 400%. So virtual care is here to stay. It's only going to increase. Go ahead, Adam. I know you want to talk on this one.
Well, I know, every one of these, right? Here's the funny part, folks. All of you in attendance, we should have had a poll question of, how many times did Adam interrupt Rob and how many times did Rob interrupt Adam, right? But the point of this is really simple. Virtual medicine is here to stay, like you said. What type of virtual medicine? Is it telemedicine where you're just calling a random doctor? It's not the same doc every time. You don't have that loyalty there. Or is it direct primary care where you have a doctor, you're texting that doctor, FaceTiming that doctor? One of the interesting things that you shared with me, and I talk about this all the time, is one of the fascinating results of behavior when it comes to COVID. Mental health claims
absolutely
are skyrocketing, right?
Off the grid.
And the fact that we're seeing over 60% of all telemedicine, a lot of it ties into mental health.
Yeah.
I always wondered, how good could that be when you're just on a phone with somebody? It's a mental health issue, right? Do you need that hand-holding? Again, another issue for another day, but the bottom line fact is DPC is on the rise. Telemedicine is on the rise. Yet, what we've noticed is that even though 85% of our audience acknowledged that COVID has changed the landscape forever, what we have seen here at Phia is that 32% of all of the plan documents that we look at for 2021 have no mention, no changes as it relates to COVID, telemedicine, how payment methodology as it relates to how do you pay for virtual care. Are you paying the same amount as you would in a normal office environment? So a lot of questions that need to be answered and a lot of issues that have not been resolved.
And so there's a live question here, Adam. This is an interesting one, and I don't know that we have the full answer to it, but I'm going to read it because it ties back to what we just talked about. How did the stop-loss companies make out this past year compared to the fully insured? I'm going to take an educated guess, right?
I got the answer on that one. If you want to do it, take a guess first. Go ahead.
I'm going to take a guess that they fared fairly well with one exception. There are some large unexpected COVID claims that probably popped this year.
No question. So we're looking at last year, right? So in the past year, it's no different than the insurance companies. So if you think of the insurance carriers where they're taking on all the risk, right? It's fully insured, right? They're taking on all that risk. So that's what stop loss does. Stop loss takes on that risk as well. So we here at Phia, obviously we have many stop loss clients. So when I started seeing renewals, and when I started seeing the quotes, 10%, 11%, 8% increases, the first thing I said was, how in the world can they justify that when I know the overall claims volume based on the 15 million lives we serve is down about 35%, just volume of claims.
Correct.
On an entire
we saw that in our business, right? Vālenz is in the claim business at our peak, and I'm sure there are other claim organizations and TPAs on this call. They can attest to nodding their heads, hopefully. At its peak, some of us saw 50 to 60% reduction in volume before it kind of started to move back to quote-unquote normalize.
Exactly. So then how can you justify if they all did so great in 2020, how could there be increase in premium in 21? Really simple, folks. I'm going to tell you how. Preventive care is cheap care. It doesn't cost a lot to do a cancer screening. It costs a lot if a person doesn't have a screening, and then it's too late. And then a year from now they find it, and then they have to operate.
So you're leading us, Adam, as you always do so great here, to the delayed care concept, right? So this delayed care has two pieces. One, cancer hasn't gone away. Diagnosis of cancer is down, but cancer didn't go away. People just aren't getting to their visits. And what we're seeing and what I'm anticipating, and the answer to your 11% increase from my lens, is that they're preparing for the whiplash effect. They're preparing to start to put the money back in reserves and prepare for the day when delayed care creates later stage, later stage diagnosis, more severe cases. That's what's going on right there.
As they like to call them, catastrophic claims in the stop loss.
Preparing for it. We're preparing for it now, right? We're preparing for it now. So again, and the last piece on this page so that we can continue to move forward here with some of the other content, data and transparency. And those are two big words, right? Data is a small word, transparency is a long word, but they're both really big. And again, wrapping yourself around this ball to the right, what brought us here won't take us forward, reimbursement strategies. How do you take everything that's happening in this environment today and everything that's happened to us all? By the way, I was talking to one of my internal folks maybe 2 weeks ago, and I said, shared experiences is an interesting thing, right? You and I, Adam, we have personal shared experiences, but we have a global shared experience now, something that certainly in this lifetime, this generation has never seen before. We're all dealing with the same thing. We're all feeling the same thing. We're all emotionally connected to what does normal look like? When do I return? What happens in reimbursement strategies in an environment like that as well?
No question about it. As you go to the next slide, one of the things I wanted to make sure we focused on was data, right? Because I think what a lot of the audience automatically assumes is, oh, well, what's the big deal? Data is data. How you price a claim. Folks, it's not the same old days. This is not 5 years ago. How you price a claim matters today. Come on. As you see more and more hospitals fighting, trying to collect that money based on all the revenue they lost, right? You better have audits done. You better have details as it relates to how you came up with those repricing guidelines and that data. That data is going to tell a story. And how you tell that story is going to tell you whether or not you're right or wrong on a particular claim.
So I think the count's up to 3 because I'm going to interrupt you. So the sources of data that you use and how you kind of bring them together also matters, right? This cost plus design of Medicare, it will work, but only for so long. There are other sources. There's usual and customary data and where you reimburse at a percentile level, and how does that compare and contrast, right? There's paid claim data and what providers have accepted as reimbursement in the past, all of that good stuff. So while we're doing this, I think we have a second poll, Aaron, if that one's going to pop up on the screen for folks, that'd be great. Because this one really, I think this one, Adam, as we talked about, this is going to tie right back into the next two pieces we want to kind of get into with the audience.
Hey, Rob, I can go back to last year's webinars that I've done, right, where we asked this question, and I don't even think the year 2022 was even on as an option, because no one thought it was going to be around this long, right? So
No.
I'm not gonna answer this question because I've been a fool one too many times.
Yeah, I think, and that's the confusing part of this topic too, right? There's so much disparate information that's being thrown at the general public, and how do you decipher what you're hearing, and how do you filter what seems reasonable? We're getting to a place that it's interesting, and we'll share this with the audience so they could see what they thought collectively as a group. This is an interesting mix.
Rob,
is an interesting mix.
Here's the thing, right? And you can, this is a separate question for a separate day, right? But you add on to this, how many employers are going to require that all of their employees come back? In the state of Massachusetts here alone, government workers, the governor's already stated that whenever we return to normal, 50% of the staff that normally was in an office environment, they're going to tell them they can just stay home.
Yeah.
So, I know that's one of the questions for my company is like, all right, are we going to say when people are vaccinated, we want them, we're forcing them to come back? Just a lot of unanswered stuff.
What's the trigger, right? What's the event? What's the moment when you've crossed? So we'll close this poll here. We'll close this poll here in about 10 seconds. There you go. That's great. And Aaron, if we could publish that for everybody, that'd be awesome, man. Thank you.
So it's a long summer. Long summer.
Interesting, as everyone can see now, right? It's going to be a long summer for sure for about 41% of us, and some of us think it's going to be a long year the rest of the way. Over 50% of you say January 2022. And by the way, I would probably be in the category that sits in that November to January timeframe if it were me, just based on what we're seeing.
I would too, and I can tell you as a father of 4 kids, the oldest being 7, the fact that all of my kids have been in school every single day in September, I can't even imagine a virtual setting for another year or another half a year. Insane. All right, but let's get to this slide, Rob.
Let's get to this one because this is really important. I think this starts to begin the conversation about how do you build and what do you look at. And innovation is a big word again. And what does it mean? It's change. It means taking what you know, what's worked, what hasn't worked, what you think you're going to do today, and trying to prognosticate or predict what you see going on in the future. How do you innovate to prepare for that? So we picked 4 key areas that we think are tied to this topic. Transparency. Adam, I'm going to have you talk about that one, okay? Data-enabled decisions. We want to talk about member navigation and engagement, and this is really interesting. I want to just give you an exclamation point to that one because this seems to be popping more and more. And Adam, I know we talked about this as we were preparing for today's session for the audience. Aon did, again, from one of their published reports, and I'm just going to read this quote to you. And if you don't have anyone helping the member navigate these new models, all bets are off. Say that again. All bets are off. You could do the best in the world in designing reimbursement strategy. If you don't engage that member for this experience and help them through it, it ain't going to work. So close gaps in cost and quality. So please, go on, bud.
We talk about cost transparency. Right there, complete transparency. Folks, I'm going to say something that's going to probably be like, people are like, what? Did he just say that? I'm not in favor of complete healthcare cost transparency direct to the membership. And I'm going to give you a 30-second story as to why. Back in 2018, Payless shoe stores. You guys all know what Payless? I used to go to those kind of places when I was a kid. My mother raised my sister and I, single mom, 3 jobs. You can get shoes for $20. In 2018, Payless opened a small, they just did this as a joke. They opened a small boutique store, Rob, and they called it Pelosi instead of Payless, okay?
Yep.
And they took those same $20 shoes and put $800 price tags on them. Same shoes. They hired good-looking people to sell the shoes, and then when people bought those shoes and they were told, this is a $20 shoe you just spent $800 for, why? They go, well, it was $800. I'm assuming the quality of the shoe must be amazing.
Mm-hmm.
Bingo. If people only see the price, they think it tells them the quality. And we both know that that is not the case when it comes to healthcare. You cannot expect transparency by only seeing the cost.
There's no one-to-one correlation there. But, Adam, we're complete transparency, working our way around the circle to data enabled. And there was a pre-submitted question that I think you can help us kind of connect the dot here and have this conversation on the balanced billing question. That very first one, could you maybe read it to the audience and maybe talk through that, or if you'd like me to?
You want to read that, if you don't mind?
Yeah, how are balance billing questions best addressed? And is it the legal defense always offered to the member, or is this an added expense that should be factored in when RBP firms are retained? And so we'll make it less personal to us and more broad about the topic again. Go ahead, bud.
Got it. So, folks, in the old days, you were able to get away with an idea that you're going to have this cost information. This is what you're going to pay to a facility, and that's it. If you are working with any, I don't even think that you could possibly anymore work with a vendor where it's only based on pricing the claim. There must be some really detailed, defendable, balanced billing processes in place. There should be a legal presence in that piece. Why? We just spoke about it 10 minutes ago. We talked about what's happening in the hospital setting. We talked about what's happening in the facility setting. They're getting $50 million less per month in revenue. There is a bigger need to collect funds, a bigger need, more appeals, higher volume of claim appeals, more in-depth analysis being done by these facilities who are also hiring law firms to defend their right to collect. So I don't think it's a matter of whether it should be an add-on. It should be part of the overall process. But then,
Yes.
what process is the best process to work with? What type of approach do these organizations take? Scorched earth approach, let's make a deal approach, proactive outreach to facilities prior to services being rendered, all that needs to be considered. But this idea that there is no defense, no assistance of the patients at all,
Yeah.
that's 2015, man. That doesn't exist anymore.
Yeah, you're right. And I got to tell you, thank you for the audience. Love these questions that are coming in right now. They're just phenomenal. I'd like to tackle this one, Adam, because I think it ties also here as we kind of get around the circle, which is what are some of the best strategies for aligning physician providers with this new model? This is a great question. And so what if you think about this member navigation process and you start to think about in a quote unquote so-called open access referenced plan, how do you engage, how do you direct, how do you control, and then how do you negotiate? And so there are a variety of different options available. And again, we're not going to make this about what Vālenz is doing, but in the market, there are solutions that pre-engage using data from past claim history to get to those specific providers up front and begin to share with them what the plan is thinking, what the member is looking for, and get them to kind of pre-engage in this process, accept reimbursement levels at a certain level, maybe even get them under a specific recurring agreement for certain services at a discounted rate. Adding quality into that conversation, this is where value-based care potentially has a place in the discussion as well. It's a great question. Really appreciate you bringing that to us. That question ties back to data, transparency, member engagement, and provider partnership. All of those ingredients come together. Go ahead, brother.
Rob, tied into what you just said so eloquently. That much more eloquent than I could ever speak, by the way. People ask me all the time, so, Adam, what do you charge for balance bill work? I'm like, that balance bill charge depends on what Rob just said. How much engagement is there before services are rendered? Folks, and I'm sharing some insight here. You can get balance bill defense work done when there is real proactive engagement with membership, where you have all the things that Rob was talking about, and get that at, $1, $2 per employee per month. You take that out of the equation and have it that, okay, it's the Wild West. We're going to pay the claim and just, fingers crossed, hope for the best from a facility and member engagement standpoint. Now you're talking goodwill issues. Now you're talking noise. That same $1 price is now $20.
Yep.
Because the volume is tremendous. This is a key. Whatever you do, this idea that education of members isn't important. Training them, being transparent with them, giving them the right navigational tools, whatever they may be, apps, phone, people on the phone, care navigators, whatever it is, those things need to be in place, especially in today's environment.
Absolutely. And overlay on top of this conversation now as we kind of come around the curve with what we talked about earlier about behavioral health. Interesting statistical data, $102 billion economic cost to the workplace environment is behavioral health. 20% of the population, Adam, is healthy. 60% of the population is coping or struggling. Those are your EAP and kind of virtual lights. And then you have 20% of the population that is generally unwell. The concern is that that's the population that's being left behind, and if without the proper types of plan design and program and access, something we haven't talked about, they're going to be left behind. You're going to see bigger gaps now going forward.
Well, Rob, one thing, the data tells you everything, right? We've learned that over the years, right? And we tell people all the time, first you need to evaluate your data. That data is going to tell you a story. And then based on that story, that risk, you then design your plan document to that risk. And what I'm telling people all the time is, sure, we're seeing claims volume way down. But Rob, where is claim volume up?
It's in
behavioral health claims, mental health claims. We've noticed that the number of prescriptions, brand new prescriptions for antidepressants, has skyrocketed. Whereas in your plan document, maybe you really, let's be honest, most employers really haven't spent a lot of time addressing mental health issues, behavioral health issues.
Yep.
And those claims typically are in treatment facilities, out of network. Those are the claims that have the biggest fraud, the biggest overcharges, the biggest abuse, and we're seeing a massive increase in them. So
Absolutely.
That data is going to tell you that story, and working with the right companies and partners proactively is going to help you mitigate that overall risk.
Yeah, and this is prominent in the Aon study we'll share with the audience once we conclude this. Mental health is the biggest employee well-being issue defined by some of the largest corporations in the country today, and that it's really, really important from a steerage, direction of care perspective to get optimal providers and optimal outcomes, cost, quality, utilization, to get the best outcomes in this clinical ecosystem. So we'll move forward from this. This is hopefully very exciting for the audience to hear us. So let's talk a little bit now. We'll dive in, and I'm going to start at the bottom, and it's going to hopefully help us move, Adam, through this conversation, which is the overarching question remains: will current factors impact the development and deployment of a strategy? And let's replace RBP or complement it with reimbursement strategies, okay?
Right. Whatever they may be, however you decide.
However you decide. And so there's that four-letter word again, data, right, which is a four-letter word we can use publicly here today. And how do you balance cost, quality, and utilization, which, by the way, we're going to argue later in the broadcast, should be pivoted from cost, quality, utilization, which is an RBP first strategy, to quality, utilization, and cost, putting cost at the back end of the discussion. Because if you do all the right things up front, the cost is going to be where you need it to be to get the problem resolved. How do you bring visibility and transparency? Again, a word we want to define. So go ahead, man. Tell me what you're thinking here.
I mean, I want to go back to the first. I mean, this is now we're talking about quality, right? And what you said about quality really impresses me, from the fact that you said quality first. What we have seen in the industry, and we're noticing it change, but what we are seeing, even for those companies that are being proactive as it relates to proactively trying to get direct contracts in place, et cetera, is the focus is only on cost. And then if they are looking at quality metrics, the quality is almost like, all right, as a way to support the cost. It's not used as the defining element. It's as a supporting element to why we decided to make this deal.
Absolutely.
And then where are they getting those quality numbers in the first place? Are they measuring the quality of the physicians and the surgeons within the facility, or just the facility? Rob, I don't know about you, but when I went to law school, right, and I was top of my class.
Of course you were. Everybody here was expecting you to say that. Just say.
Right,
I'm just saying.
I know.
We all believe that you believe that. Go ahead.
Even if it's not true, I think it, right? But here's the point. There's the 20% that were at the bottom who graduated, okay? Mm-hmm. So when you're hiring a lawyer or a doctor, a surgeon to perform your knee surgery, don't you want to know that even though we all graduated from, whatever, XYZ law school, these guys in the top 10%, these guys in the bottom 10%, there's a difference there. Absolutely. And the same thing when it comes to surgeons at a particular facility. You might say the facility has a great quality ranking, But if there's 5 surgeons doing the same surgery, they're not all equal, Rob. And diving that deep into the weeds when it comes to quality should be a priority, not a secondary add-on feature that is looked upon in today's world.
There's a live question that we want to tackle here, and it's specific to Vālenz, so I'm gonna tackle it as best I can without it being an infomercial, and I'm gonna read it to the audience. How important is it in closing the communication gaps in having multiple members involved in case management, RBP, and administrative services? And how has Vālenz closed those gaps, and what data do you have to support success of having your fully integrated approach versus the old, and are there any success stories pointing this out? So the short answer to the last question is yes, and whoever asked that question, we are going to provide that to you, and if the rest of the audience is interested, we're certainly happy to provide some success stories on how an integrated approach drives better overall clinical and cost outcomes. Now, I'm going to tackle the first part of that question, believing that what's being asked, and I apologize if I'm missing this, is if you have multiple suppliers with different data sets on the same member versus a single thread of a integrated approach where the member is being touched and the data is being managed real time, that's what our solution is. So the ability to navigate, direct care, support the member, bring them into a reference-based and or a narrow network that's contracted, and then handle all the subsequent claim, edit, fraud, waste, and abuse checks, all of those things that happen on the backside, and then the payment. If you're working with one organization that does all of those, like Vālenz does, you're able to take all that data, Adam, real time, and audience members, real time into your data warehouse like we do, and run analytics and algorithms and predictive modeling, and you're able to quickly assess early on what is potentially a risk-based claim for going left, going the wrong direction. Later here, we're going to show you something called a claim cost arc. It's what we've trademarked as the way that we like to look at how you manage and balance this. And so that's going to be something that gets touched there. Adam, while you're going, let's let Aaron kind of throw in this next poll question.
Yeah, I'm actually really interested in seeing what people think on this. For the future impact of reimbursement strategies. One of the key things I think we touched upon a little bit is, and I'm going to put a pat on myself on the back, my transcripts will be made available. I saw that live question to come in.
That's a great question. I don't know who asked that question, but I want to say I love you. That is a great question, and I was going to ask afterwards, but now it's on record. In the name of transparency, will Adam supply all of us with his law school transcript?
I will give you all my transcripts for everything, okay? Everything. Marriage certificates, whatever you want to see. Birth certificates of my kids. I am a very transparent person. But in the sake of this and the time we have, at Phia, at my company, and I'm patting myself on the back of this because this is something I'm very proud of, my employees and their family members have free health care. Rob, it's free. Everyone at Phia has free health care. And people say all the time, well, how do you do it? It's because the stuff that Rob and I are talking about, we didn't put it in place last year. We put these things in place 7, 8 years ago. We're not, what we see in our industry still today, Rob, annual enrollment meeting. What is that? You don't need enrollment meetings. You need workshops. You need to treat your healthcare expense no different than every other expense. So what I find is CFOs, I talk to all the time, I go, in order for someone to get a 5% raise, self-evaluation, peer review, annual review, biannual review, goal setting, they do all these things for someone to get a 5% raise, right? Yet that same employee can go out and get a $100,000 surgery by a low-quality physician at a low-quality facility. No one does anything about it. That's the point. You should spend as much time on that expense as you do on your salaries. And that's what we have done. We've been able to identify what we have found, Rob, is, and again, we're a young company, but where's our biggest expense when it comes to healthcare? Babies. Delivering babies.
Absolutely.
Sometimes there's a preemie, right? Sometimes they're in ICU, NICU, etc. Identifying the best facilities and then steering our employees to go to the right facilities, at the best facilities at the best prices. That's what we focused on. Same with pharmacy.
You're bringing babies in, so let's have this. Thank you to all the women, National Women Leadership, right? Week, day, and month, right now. Thank you for all of the leaders right now. So thank you for all you do. All right, Aaron, let's close this poll. Let's share this
Interesting.
with the audience. Interesting. Really interesting, right? So
It's all over
24%
the map.
of you. Yeah. The only thing that seemed a little bit off was the DPC options, though not terribly off in terms of prominence. It does appear that the winner would be virtual first, which probably makes sense.
And I want to make, I have a comment on that. And I think where people are short selling DPC, I have DPC on myself and my family. It is by far the best thing we've ever done on our health plan design. And the reason why I tell people that, it's not just about the fact that I can have a FaceTime call with my doctor. Our DPC practice, the practices that we work with, they actually know our health plan. They know our design. They know the copay structures. They know what generic is versus what brand is. So they are what I like to call the gatekeepers. When they're sending someone out to an MRI, folks, you realize that when a person goes to a health system, the MRI that they're sending that person to is a $5,000 MRI machine versus a $500 freestanding MRI machine. So it's not just the DPC doctor as that one-on-one. It's their gatekeeper of what they refer you out to, testing, all that stuff. Those costs are the big costs that having DPC helps eliminate.
Absolutely.
So you guys are wrong out there.
Hey, we're going to move forward here in a second. An audience member wants to know if you're hiring, Adam. Apparently, you've reached them in a way that's impressive. So there you go.
We always are, but it's only as my executive assistant. So unless you want to work for me, if you're having free health care, if you're willing to put yourself in that role, then you can have free health care. Yeah.
So we do have a comment. We have a comment here, and I hope the audience member doesn't mind that we're going to read it because I think it's probably something others are thinking too. I run a Taft-Hartley plan serving for farm workers who are predominantly Spanish-speaking, and living in rural areas scattered across 7 states. We're using RBP. We're having some success, but getting engagement to the degree we've described is nearly impossible under their particular circumstance. The big cases in terms of cost are probably only 1 or 2 per month, and that's where they focus their attention, Adam, because we could save hundreds of thousands instead of fighting over small amounts. We're having some success, but not necessarily with the level of engagement you suggest. So I know it was a comment. There wasn't really an intended solution being sought for there. Sounds like you're doing a really nice job. There are some things you could potentially consider for engagement as well that we'd be happy to talk about.
What I love this person is doing, Rob, though, is not sweating the small stuff. Folks,
amen.
Do you have any idea, Rob, how many reference-based pricing situations we've had where the plan is saving millions of dollars, yet what they did not solve was the noise. So they'll have 500 open balance bills. Now everyone's like, what, 500? Folks, here's the scary part. 90%, and I'm not making these up, but this is legit, 90% of the balance bills that are noisy were under $1,000. Pay them.
Yeah.
Pay them.
Just pay them.
Pay them.
Just pay them.
Because the reason is when you don't pay them, those people are going to HR. And the more noise HR hears, eventually you end up going back to the old alternative, which is being fully insured, right? Going back to that old school plan. So many amazing, innovative programs have been lost because people didn't do what this person is doing, where they're not sweating the small stuff and they're focusing on those big claims with the big bucks and they can resolve them and help that plan going forward.
Absolutely. And organizations like ours, specifically in this case, Vālenz, we agree with that, and we're working on, and I think some of our contemporaries that we compete with are doing the same, to try and create risk-free types of solutions that are guaranteeing on those smaller dollar claims to get people less focused on that and begin to innovate and engineer solutions that tackle all the issues we talked about on slides 1 through 6 today, and begin to really focus on the conditions that are going to truly drive improvement in the wellness of your members and the cost management of your program. Amen,
on this slide alone, all I want to say is the fact that you have all 3 of these. Are they circles? Not really.
They're a little bit oblong. They ate a little bit over the evening, so they grew. They grew.
Okay. But they're all equal.
Yes, they are equal.
That's all I need to say. And that's the point, right? Is that you're not putting one over the other. You're saying this is important. Utilization, right? How many times? How big of a player is this facility going to be? How many issues are you potentially going to see there? Are these people in a rural area or not? You know, I love when people say to me, well, what's the cost? You know, what do you recommend? I'm like, where are you?
Yeah,
What type of
absolutely.
plan design? Are 90% of your people in one state? Are they in one town? Are they all over the place? You know, I go back to that same comment that we just talked about with the Taft-Hartley plan. What that person has told us in that one comment, Rob, is more than I typically hear in an opening monologue from any potential client. They're
Yeah,
telling us what their
absolutely.
situation is.
Yeah, I
Perfect.
just want to, and we'll just recognize there are some very nice, we're not going to read these, but there are several comments, Adam, about our own organizations and some of our customers praising and thanking us for putting this on and all that we do for them today. And so those that are our customers collectively, the two of us say, we sincerely thank you. Our teams are just delighted and grateful that you are partners with us. On this page and the next three, you're going to see this claim, what we call the claim cost arc. This is Vālenz specific, so I just want to let you know what you're looking at. We measure success in terms of how we bend the cost arc, and that's what we call it, a claim cost arc. And we manage it from pre-claim loss to what we call post-claim resolution. So there's stuff that happens after the claim is paid, but there's still ongoing issues and challenges and opportunities to manage and keep these three triangulating pieces in balance. Pre-claim loss really is what we talked about earlier. It's data and transparency around what are the opportunities in your program before somebody even takes hold and starts working on it. How do you design plans around it, etc. These are innovations you need to be thinking about as you go forward with your plan. So I'm going to move forward here, Adam. Let's talk a little bit about cost. And again, I said, and I shared with the audience, you know, we talk about it as cost, quality, and utilization. Eventually you're going to see this type of a conversation put cost at the back end because it'll be managed, it'll be appropriate, but we don't want to start with cost per se. But today we're still in a cost forward kind of environment. And so these are the 6 that we could come up with, folks in the audience, relative to concierge level navigation. It's going to help you with cost. Pre-service contracting negotiation, something we see emerging. We actually distributed this earlier this year. We started bringing it to market. Adam, I know you want to talk. Let me just get to the right side real quick, and then I'm going to let you go. Post-service provider contracting. You know, this is what has been the staple of our industry. That needs to become less prominent. It needs to be done up front in partnership. Go ahead, man. Go ahead.
A couple things I want to add on to these great points that you've made. Number one, what's going to also measure the cost and lower that overall cost? Speed. How fast can you pay them?
What matters in speed, by the way? What matters in decision making? Data. The faster you have good data, the faster you can take that data, the faster you can assimilate data along the continuum of that claim cost arc I just mentioned that's up front on the screen right now, the better chance you have of enabling smarter decisions for a program. Go ahead.
How about this? How about the fact of this, right? Let's take that person who brought up that I love that person. I don't know who they are, but I got to find out their name. Because they bring up so many ideas in my head. That same Taft-Hartley plan. What if before they put whoever it's with, whether it's Vālenz or somebody else, let's say they have, before their reference-based pricing solution, they had a regular PPO network. And now they're switching. When they had their PPO network, there was a $5,000 deductible and a $100 copay. Let's just pretend, right? Yep. Now they switch, and they still have a $5,000 deductible and a $100 copay, Rob. Yeah. That's going to affect cost. That's going to affect reimbursement. That's going to affect noise. Because what people don't realize is if a provider still has to chase that $100 or that $5,000, right? That's not going to help you, the plan, in regards to what you can do.
We have a live question.
Yeah, that schedule of benefits is huge when it comes to this.
Yep. We have a live question that I want to bring up here, and we're going to ask again at quality and utilization. You ready? It's right at the bottom of that last section. I'm more comfortable with the traditional BUCA plan, Rob and Adam. What are the real benefits of the model you're describing? Let's start with cost. Let's stop there. Let's get to the qualities page and talk a little bit about the differential there and utilization. Go ahead. Go ahead. Let her rip.
All right. Well, the next one I want to talk about is tied to quality.
Yes.
Because you want to go to the next slide then? I don't know. It's up to you.
Yeah, let's do it.
Okay. So, again, I'm going to make it very simple. BUCA plan. Whoever this is, I, at Phia, have a self-funded Blue Cross Blue Shield self-funded plan. So I have a BUCA plan. It's self-funded. However, out of network, we pay through a reference-based price process. Now, here's what I'm going to tell you. I want you, whoever this person is, to go on your Blue Cross Blue Shield network right now. Go on the website. And I want you to find quality. Show me right now, literally, once this is over, whoever this is, at 2 o'clock, go on your Blue Cross network and tell me how you can look at the different quality levels of different pediatricians that are taking care of your child.
Yeah.
They don't exist.
Nope.
That's the difference. The difference is when my mom, who has MS, 17 years old moms have MS, and when I needed to find a neurologist, I didn't just go on, well, this person said this is the best neurologist, right? I went and I was able to, based on the amazing tools and friends I have in the industry, people like Rob, I was able to identify who the best neurologists are. Forget about cost even. I'm putting quality first. It's my mother.
Correct. And that's...
You can't do that on a Blue Cross United Cigna network. There's no way you can go online. There's nothing you can do on that network because they're not allowed, they are not allowed to steer people to any one provider over another.
Yeah, the old acronym, right? The old acronym used to be AWP. Any willing provider is part of that network. Anyone that wants to join can, and that's what creates some of the burden, right? So, and I think the audience probably does understand this, but part of the value of narrow networks is you are working with a slice or a very specific group of providers, and there is a direction of care requirement and expectation to guide them into those high-quality network providers. RBP plans, some of the pre-service negotiation, they need to move. My opinion, and this is opinion, needs to move, and I want the audience to understand that, need to move in that direction too. So you really can get quality, you really can get direction of care, you can get relationship going on. So I see we're going to get another poll here, and while we're doing that, there is a really good question, a really good comment in here. Do you see this one, Adam? How many providers do you come across? Did you see this one in live? How many providers do you come across that don't even realize how much a reference-based approach will increase their cash flow and bottom line until after speaking with you? I personally, this audience member, I've come across many in my experience that had no idea that this strategy actually helps them. I'm going to get your name because I love that question and that comment, and you're spot on. Spot on. Any comments, Adam?
It's 100%. I mean, what we do at Phia, is that's what we deal with, right? We deal with these claims. And when you do talk to facilities, the first thing that we realize is we're not using the same language. It's as if I'm talking Polish and they're talking Spanish. Okay? It's literally, because and now it's starting to change, but depending on where you are. Like if I'm in Texas, when I'm talking to a billing office in Texas, they know what Medicare Plus is, reference-based pricing. They understand all that jargon. If I'm talking to Massachusetts General Hospital, no clue. They'll say to you, we're offering a 25% discount. I'm like, man, I'm not talking about discounts off your fake charge. So once you get past that piece, once you get past that language barrier and you're actually on the same, and you're talking the same language, then it's about cash flow, how quickly that money can flow in. How much less time their billing offices spent chasing pennies when they could be focused on dollars.
Absolutely. So it goes back to the question that was brought up by the Taft-Hartley person, right? I'm gonna fight the right fight, and I'm gonna let the other stuff, the small stuff, not sweat. And if somebody wants to help you with your challenge, they're offering to be your BOR to get you off that Blue Cross Blue Shield ASO plan. I think it's a great offer.
I'm not an ASO plan.
Okay.
If I was with an ASO plan, I wouldn't be able to do the things I'm talking about. You think I could offer free health care to my employees and their families if I was on an ASO plan? I'm on a TPA, Blue Cross Blue Shield rental plan in Massachusetts. So my discount aren't as good, but I'm allowed to do steerage. I'm allowed to do all the things that we have done. So I appreciate that comment, but you're incorrect about what we do.
We've closed out the survey. Interesting, 90% behavioral health, future health plan, critically, and very.
Well, here's the thing. Discrimination testing on mental health claims, it's a requirement this year. Good luck trying to find a vendor that even offers it, number one. But that is going to be no different than the 105 discrimination testing that you have right now in your health plan designs. Now it's going to be the same exact thing for mental health that people have to deal with. One point I want to make sure we bring up. If all of you think this is so important, then why isn't it being addressed in your employee handbooks and the plan documents? You have to have your plan documents aligned with what you expect to happen in the future. And to go back to what Rob was talking about on the cost and the quality piece, stop loss is key. What people still don't realize is if you align with the wrong stop loss partner, your reference-based program can blow up. So it doesn't even matter who you're using, how great it is, how bad it is. You need to be aligned with stop loss from a standpoint. Sometimes you have to negotiate more. From a strategic sense, a noise sense, a goodwill sense, it just makes sense because for the bigger picture of the overall plan, you're going to negotiate. Yeah. But did you get that authority from stop loss in your policy to authorize additional payments? Or are you left holding the buck?
I have to interrupt you, brother. We are getting such great comments from people. I want the audience to get the benefit of some of these. Actually, we have always had low copays and deductibles before and after RBP. And for the BUCA question, you'll pay hospital claims at least 250% of Medicare. I'll add, depending on the jurisdiction, could be much higher than that too, after discount, if you want to even call it a discount, Rob added. And with RBP, we are paying between 140 and 200% of Medicare, good for you, and are still bringing that down. In our case, it's a couple $1 million per year average. Yeah. Wonderful, wonderful, great comment. We love that. Thank you. Last comment on quality before we move forward. You can't manage what you're not measuring, and so you got to find ways to measure quality. There's not a lot out there that's standard. We own that. We own that. We, the industry, we, the people supporting these members and these employer-sponsored plans, we own that. And it's in these areas: network design, virtual care. You know, another day, RPM, not revolutions per minute, remote patient monitoring. New certification available from URAC now for those that don't know that. And it's going to be tied directly to the impact of virtual care, more serious diagnosis, delayed care, etc. That RPM is going to become critical. Thank you, Aaron. All right, man, let's move on. We got 2 more to go here for this audience. Hopefully we're keeping them engaged and excited about what we're talking about. Data again, dude. Data again, right? Isn't that the word on this page? Data. Data.
Utilization.
Yeah.
That's the key. At the end of the day, the data is going to tell you that, right? So if you notice, the data is going to tell you cost. The data has a lot of elements to quality, right? How do you get quality information? Readmission rates, infection rates, complication rates. How about just knowing the number of times that surgeon actually performed that knee replacement surgery in his lifetime or her lifetime? Knowing that information. All this is key. But the key problem that we keep on seeing over and over again, medical necessity, how that's defined in the plan, not matching to actually how you're administrating it.
Absolutely.
Or how the handbook talks about it. Folks, one of the biggest problems that we see is the thing that we'll see, especially when we get a case sent to us from an outside entity, right? The one that we don't normally work with. They'll say, Rob, I'm not going to make this up, $16 million claim. One patient.
Yeah, I know. We talked about this. Yep, we talked about yesterday.
Okay, right? The first thing the hospital does is says, we want to see the copy of the SPD. Why? The SPD does not align with what our administrator was doing on the claim. And that's how they catch you. So regardless of how good the quality, the data, etc. is, you still need that plan design to literally match what you're doing claim by claim.
And while you're busy with that plan design, correcting for things that are happening today, ties perfectly. We got 5 minutes left here, Adam, to wrap this thing up on the next page. We wanted to bring ideas to you about what to think about for the future and how you look at designing plans. So this last page, again, remember we told you we weren't going to give you a turnkey solution. That was not the intent here. But these are the 9 pieces that we really think should be balanced in this conversation as you start to think about reimbursement strategies, plan design, taking care of your members, covering your costs, all the things that are critically important. And we will read a little bit here just for the audience, right? So from an improved access perspective, the models that have concierge are going to be the ones that work. Giving that member experience is critical. How you do contracting, and that CQU becomes QUC in a future engagement, is critically important here. In RBP, you're still doing contracting. In a future RBP, you're going to be doing more contracting. You're going to be setting up partnership. This is what we believe is true, because then you can make sure you're getting the right kind of access. And you got to build modes of access that cover everything. We have a plug-and-play design for direct primary care, where we can take them from inception, virtual care episode, into a DPC referral, back out to a face-to-face if they need to a specialist. That's what you need to be thinking about, flexible plug-and-play design. Adam, go ahead before we move on.
So we talk about improved access. Here's one of the things that we've seen. So we're thinking, all right, you want to have these innovative models, right? So that means calling people on their cell phones, texting them, right? Well, Rob, one of the problems that we've seen in the self-insured industry, as many of you know, I'm a vocal leader in SIA. I was past chairman. 30% of the administrators in our country right now, they're in SIA, don't collect cell phone numbers. So it's really hard to establish models unless you actually have patient contact information of how you get in touch with these people. That's one piece I want to bring up. The second piece I want to bring up is when we talk about, you talk about contracting. How you as a broker, how you as an administrator get paid for these things. That's another key element that you need to discuss going forward, because the payment methodologies are changing.
Yes.
We saw right now in Congress, all the broker, you have to, obviously show and be transparent about how you make money going forward. So is it tied to a percentage of savings? Is it tied to a per employee per month rate? How is that baked in as a revenue stream?
It is. So I want to go down the center of the page real quick. I'm going to focus on the bottom first. You want to align the financial goals of all the players. If you don't have alignment between the member, the plan, the payer, and the provider, DOA. Done. Second, savings shouldn't be a mystery. Costs should be transparent and visible. Let's get common definitions. Let's make sure we describe what we're talking about in a way where everybody involved agrees, and then you can have a fair conversation. I know you want to talk. We got 2 minutes.
I was just going to say, go back to that savings and costs. When people tell me, oh, we're able to save get an 80% discount, 80% discount. I'm like, yeah, off what? What's the charge, folks?
Yeah.
I could, there are plenty of situations where an 80% discount is actually more expensive than just paying 100% of what the cost is, plus a Medicare reimbursement rate. I mean, Rob, I don't think you shared, just how much if our entire country went to a Medicare plus, just a Medicare reimbursement model.
Yes.
How many billions of dollars are hospital systems?
$325 billion. Just published yesterday, if you saw the ad. We got 27 seconds. So I'm taking 12. I'm giving you 15.
Oh.
Higher quality, engagement, manage, measure. I want to personally thank the audience. I really want to extend my affection to Adam Russo, a friend and a business partner. Thank you for doing this with me today, Adam.
I think the fact that we were able to do this virtually is a blessing, because otherwise we'd be pushing each other for airtime. But honestly, Rob, you're one of the smartest guys I know in the industry. You're a friend of mine, and I got a lot out of this. And I'm just a guest, so I'm hoping that the audience did as well. But I want to thank everyone for the opportunity to be here today.
Aaron, I'll turn it back over to you.
Absolutely. So Rob, Adam, thank you so much for a wonderful discussion this past hour. And that's it. Once again, thank you, Rob. Thank you, Adam, to all of you. You could have been many places this past hour. We appreciate you choosing to be here with us. So this concludes our Vālenz webinar. Have a great day, everyone. And with that, we are done.